following the tooth-borne expansion scandals of the late 2010s and early 2020s, I think MARPE was perceived to be some sort of messiah where, oh, hey, we can get expansion, but by focusing on the bone and affecting the bone instead of the teeth. And yet, as the years have passed, 2020, 2021, 2022, 2023, we've seen that MARPE is actually not this foolproof thing. It can be quite problematic, specifically around overexpansion and around asymmetries that can develop with these appliances if they're sloppily implemented, or I would even say irresponsibly implemented. So my question to you is, if someone is doing SFOT on the lower arch to complement an expansion on the upper arch, a skeletal expansion with a MARPE, how many millimeters of transverse expansion can one expect SFOT to actually buy them?
Well, if I can just kind of digress a little bit.
Please.
I loved your intro. I do think that MARPE, I'm not an orthodontist, so I don't do MARPE, but I have been involved in a number of cases. My observation is that it can be quite transformational for patients and provide an opportunity unlike anything else for those patients suffering from upper airway resistance syndrome, nasal resistance, nasal flow problems. This is a significant breakthrough when done judiciously and done with, kind of the right thought leaders and so for people that really kind of have a handle on doing it well, and particularly with all the new developments of these devices. I think it's quite incredible. Like
FME or custom MARPE?
Yeah. I mean, those are incredible. I mean, I have a dear friend of mine and a colleague who is in his 60s, Ron, and he split non-surgically, and he's able to breathe better through his nose. Now, would I want to put myself through what I saw he went through? I put the MARPE in on him. I mean, it's not, when you think about what we ask our patients to go through, we have to ask the question, would we go through it ourselves?
Yeah.
With the time that, all this stuff, I mean, it's not insignificant.
And of course, your dear friend, Dr. Hutz, or I don't know if he's your dear friend,
but
I think a colleague.
He's my neighbor. My daughter babysits for his kids. I mean,
there you go.
He's amazing. He's just a great guy.
And he told me all about his MARPE experience when I had him on.
Yeah.
Positive experience.
So, you have the lower molars and you can really kind of change the trajectory so that they're loading better actually. And then you can potentially also widen. I would say you're probably looking at 2 millimeters, maybe 3 at the most transverse dimension. That's not insignificant, but it is a dental alveolar movement. And, we kind of can't, it's not meant to be a substitute for skeletal surgery, right? I mean, if a patient has a dental alveolar, has a dental facial deformity, has a disharmony, has a skeletal imbalance, if it's mild, perhaps we can manage it with SFOT. But this isn't meant to be a substitute for orthodontic surgery. But to answer your question, so many of these compensations occur, and when you're decompensating them craniofacially with skeletal expansion, and you need the lower corticotomy surgery for a phenotype modification therapy, and you're augmenting the bone morphotype to change that endochondral bone, that Starling resistor, to really kind of optimize the conditions of the teeth. I think it's a game changer, and it's really kind of changing how we look at patients from a periodontal perspective. But I have seen, when you think about the MARPE, now you have this kind of split in the maxilla. You have to kind of rethink, like, how are we going to do orthodontic surgery on these patients if they need to have them done? Because that bone bridging, is very vulnerable. So if you go in and do like a 3-piece maxilla, you may be, I guess the question is, are we opening ourselves up to complications, oral antral fistulas, which I've seen, or could some of this technology and therapy now allow orthodontic surgery to be more predictable, maybe more simple for a patient, and that most of them could be done in a one-piece LaFort versus a three-piece. So that, is something to be discussed among the team. And, I think that's a game changer in terms of how some of these therapies could improve the quality of care for patients. But for patients with nasal resistance and nasal flow problems, I think MARPE, particularly with FME and some of these newer devices, can be a real benefit. The concern, Ron, is that this isn't being taught. It's not being taught in the residency programs. It's ripe for the orthodontist to change to change this, to take this over, and to kind of become the thought leaders and to really be doing this. And I don't see that really happening. I still see a lot of resistance, which is, I guess, disappointing, because when you think about it, orthodontists are the caretakers of the periodontium at the very earliest age. And that is the specialty that has the potential to direct or redirect skeletal growth patterns to optimize, the craniofacial phenotype of the patient. Yeah. And we're still waiting. We're still waiting till the patient gets, in my view, too old, or we're not taking advantage of things because there's not an evidence-based approach. Evidence takes so much time to have a meta-analysis, to have 10, 20 years outcome. I mean, we can't wait that long if we're going to make change for, the betterment of patients.
Yeah. Yeah.
That's just my view, but I think some of this, when it gets misguided, I've seen, like you say, asymmetries. I've seen a lot, problems. And so, that's why I think it goes back to really having a good interdisciplinary team around you. Having the restorative dentist, having the periodontist, the oral surgeon, the orthodontist, everybody complementing what everybody does to optimize the care for the patient. The SFOT is really done, for, can we change the bone morphotype? Can we move the teeth through a demineralized bone matrix, which may help reduce the risk of root resorption? It will help optimize relapse. It will minimize relapse potential for the patient. It can expand the boundary conditions for patients where it may be otherwise unsafe to move teeth. But you have to have a trusting team around you, because what you're asking the patient to go through in terms of, surgery, pain, cost, all this stuff is not minimal. So, but with the right team, I mean, you can transform the lives of patients, which is incredible.
Yeah. MARPE providers, I have found, tend to use a rule of thumb about how much skeletal expansion that they go for. And that rule of thumb is that they aim to make the maxillary bone, not the teeth, but the basal bone itself, up to 5 millimeters wider than the mandibular basal bone. And then presumably they would tip the upper teeth in and then upright the lower teeth, and now you have occlusion. If sticking to that rule of thumb, where you aim to make the maxilla 5 millimeters wider than the mandible, would SFOT be necessary in a case like that? Or is SFOT on the lower arch in a MARPE case only necessary if you expand beyond that rule of thumb?
That rule of thumb relates to the transverse, does the patient have a transverse deficiency or not? So I think it's patient dependent. And some patients have a thick phenotype or a thick bone morphotype, and others maybe not so much. Ron, this is where I really think that the use of CBCT imaging and the use of simulation software programs like SureSmile, for example, that provide risk assessment from a standpoint of, understanding the impact of tooth movement on the dental alveolar complex, really answers that question better than what I can do. Because one patient may come in and they may have an exceptionally thin, bone morphotype, very thin periodontal phenotype. And yes, they need the augmentation in the upper and the lower arch to coordinate the arches and to provide them with a robust phenotype long term, so they don't have recession and they don't become like a periodontal annuity, long term. So it's patient dependent. Like, are they presenting with, so much millimeters of labial bone to begin with? How are the teeth going to move? What's the impact of that movement on the dental alveolar complex? What's the width of attached gingiva? What's the thickness of the soft tissue? These are all things that kind of need to be considered. But I do think that these simulation software programs are very accurate and can provide very good risk assessment. Just because we see, dehiscences everywhere on the software program doesn't necessarily mean that it's actually happening. But if you couple that with a very thin gingival phenotype, then or the bone is being pulled off, from the interproximal, you can see the tooth really kind of moving out quite a bit. Then that might be, cause to intervene with bone and or soft tissue.
Is that something that the Invisalign software can help you plan, or is that more of a SureSmile thing?
I think there are different software programs that are now starting to incorporate the impact of tooth movement on the dental alveolar complex. I know SureSmile was one of the leaders. I know that because one of the orthodontists I work with, Dr. Yiwei Huang downtown, he does a lot of this, and so we've been collaborating many years together on this treatment. That was actually Dr. Hutz's orthodontist. From what I have seen, I think that the Align technologies, and I think this is being incorporated more and more. But historically, what I would see would be basically a cartoon rendering of, the teeth, the crowns, and the gum tissues, and here's something crowded, and here's kind of what we're going to do. And it's like, to me, okay, it all looks good, but goes back to that, like that thinking. If you go to your physician and they take your blood pressure and they say, Ron, your blood pressure is 170, we're going to put you on calcium channel blockers. Are you going to accept that as a diagnosis? Or are you going to say, well, what's the diastolic, right? What's the full picture here? And, we have to kind of have a thorough diagnosis. And that includes not just the suprabony component, but the below the gum tissue component as well. How much are the teeth being compensated? Are they being decompensated as ideally as possible for the patient?
Mm-hmm. So just to paint a picture of how this would work. So a patient goes to their orthodontist, they have a cone beam CT done. The cone beam CT gives you a nice three-dimensional understanding of basal bone, periodontium, teeth, etc.
Yeah.
That's plugged into a software like the SureSmile software. And correct me if I'm wrong, SureSmile is a braces system. I think of it as like the Invisalign of wired braces, where you get a pre-programmed wire that comes from a manufacturing facility that's made through software and some high-tech software, essentially, that the dentist just places, and it has all the bends and kinks in it already, and then it just moves teeth according to the plan that you made in the software. So you have this software, you plug the CT, the cone beam CT into that, and you can then plug in tooth movements, right? And that software with the CBCT data will actually tell you how the periodontium is going to respond to certain tooth movements. So that if you're planning a MARPE, you can say, okay, if we do 6 millimeters of MARPE expansion, we're going to need to do this with the lower teeth to get the bite. And if we do that with the lower teeth, how are the gums, how is the bone, let's say, responding to that? And you can kind of anticipate whether you're going to be pushing the boundary of that person's periodontium. Is that right?
That's 100% right. So it provides a very thorough risk assessment for the treating team to decide, okay, do I need periodontal intervention here? Is this going beyond the limits, like way beyond the limits of what we could expect from dental alveolar surgery? Do we need to consider extraction, retraction, and maybe, advancement, skeletal advancement? Does this complement skeletal advancement? I think it really provides a vehicle to really, unleash the thinking potential and to really analyze the patient, craniofacially, dental alveolar wise, skeletal, the whole deal. So I think it's not inexpensive, Ron. It does take more time planning time for the doctor. And, unfortunately, we don't really get planned to think. We don't get paid to think. We don't get paid to plan, but
Right.
that's the most important part of everything that we do. And I think at the end of the day, that's going to come full circle, because the more you're able to plan, the more you're able to communicate with your patient, the more sincere you are. The fact that you can kind of show them the planning that you put into their treatment. And, that just kind of goes to, I think, the core of what the profession's all about, which is, really kind of doing no harm, doing the best care, and then allowing the patient to decide, how they want to be treatment planned.
Yeah. I think that people get into orthodontics in some part because of this high volume, high profit model that has been historically the case with orthodontics, where you can see dozens and dozens of patients a day and just sort of plug and chug and get them in and out and straighten their teeth and collect, right? And I'm not saying this necessarily from a cynical perspective. They're not doing this nefariously, but that's just the way it's been in orthodontics. And I think a problem with the introduction of Airway stuff into orthodontics has been a reluctance to let go of the volume approach, to take a much slower, more bespoke kind of high planning, lower volume approach, where they really emphasize getting it right instead of maintaining the volume that they've traditionally had. And so, which leads to my question, the alternative to this more thorough approach of, say, using a SureSmile software is just throwing in the MARPE, choosing some arbitrary amount to expand, 6 millimeters, 8 millimeters, or, as I've often seen, whatever the patient wants. If more turns feels better for their nasal breathing, let it rip. I've seen that. And then patients are being surprised that they now need SFOT.
Yeah.
And they're being told to get their bite back, they need this expensive, painful surgery, right? To even have a shot at getting the occlusion back. Are you seeing a lot of that? Are you seeing a lot of patients shopping around for SFOT that never were told from day one that this would be something that they would need to consider just to get their bite back after a MARPE treatment?
Ron, I would say yes and no. So the doctors that I do work with that do MARPE, which is very few, I don't work with a lot of orthodontists that do MARPE. Those that do it very thoroughly from the beginning. Again, it kind of goes back to, there's not enough people, I think, doctors doing the MARPE, but those that I have had the good fortune to be working with, I think they're doing it in a very thoughtful way from the very beginning. So most of them are not necessarily kind of surprising their patients that they need this afterwards. This has been a discussion point, at least, from the beginning. Now, what I will tell you is that I have run into a number of situations where some orthodontists feel pressured because the orthodontist down the street, is not going to tell the patient that they need SFOT, is not going to tell is going to tell them they can do it, less expensive or however, and they're concerned about losing the case, which I totally understand. And they get the patient, 90% of the way through orthodontics, and now you end up with really, almost stripping the gingival tissues. The roots are popping through the gum tissues. The teeth are hypermobile. We have to splint, 21 to 28. We have to do a soft tissue graft so that we have a robust gingival phenotype to have any potential to come back and then augment the bone morphotype. So, that is sometimes a difficult conversation with the patient, but, unfortunately, that's just the reality of practice today. Mm-hmm. So to answer your question, I haven't seen that so much in the people that I've been doing the MARPE with. But I have seen a similar situation to what you're talking about with routine orthodontic care on a couple of occasions recently.
Mm-hmm. Mm-hmm. What are your thoughts on SFOT for anteriorization, not just for transverse expansion, but for doctors wanting to actually push the upper front teeth or the lower front teeth forward to try to buy the patient a couple of millimeters of tongue space. And this sort of falls into the world of, tooth-borne expansion, extraction space reopening, AGA. Dr. Yousefian uses a procedure that he calls tapes and MAPEs, in which he uses the MARPE as an anchor to push the upper front teeth forward. How can SFOT complement anteriorization? Is that a fundamentally different thing than transverse when it comes to seeking expansion?
Some of the people that I've had the good fortune to do the MARPE treatment with, we have done the expansion, but I've also put in anchor plates to protract the maxilla as well. That's worked pretty well. Certainly to kind of get the teeth into the right axial inclination. The development of the bone morphotype is through SFOT is something that can, certainly can be done. I mean, depends on how far you're going to advance them. But I think it's more appropriate in the lower arch, because typically the lower teeth tend to be really kind of, compensated. And so being able to kind of move the tooth so that you have a better incisor angle position, and then to translate that forward is generally reasonable. I always go back and look at, like, how is the patient presenting to me from the get-go? Are they skeletally deficient class 1, 2, 3 patient? And, how far do we think we can really take them? I do think it's reasonable to consider, SFOT in view of an orthodontic surgery if you're only talking about 1, 2, maybe 3 millimeters of change. To ask a patient to go through orthodontic surgery for a very mild change might be worthwhile considering a compromise, particularly in view of the fact that they may or may not have, if we're not measuring their airway issues, if they don't really have significant airway issues, then, might be more reasonable. But back to your point, like, you expand these patients to kind of arbitrary numbers. I mean, I think we really need to kind of move to a point where we're measuring, like, how far to expand these patients, right? Not just in their face, but also, like, is their nasal flow and resistance getting better? We need to kind of measure this to kind of know, hey, we're good here. We don't need to keep expanding any further. Yeah. We're measuring this, and this is where we need to stop.
Yeah. Yeah, it makes me think of, I had a friend who was just visiting, and he's writing a novel, and he wrote a draft of his novel that took him 2 years to write the draft, and he submitted it to an editor, and the editor basically said, hey man, this is shit. Like, clearly you just sort of winged it as you went and didn't plot out every last detail of every part of this story from the beginning. And the advice that she gave him was, go back and do an extremely thorough outline of the novel where every single detail is considered, and the verisimilitude, the likelihood that the reader perceives your story as actually being possible in real life, and that it's not just sort of being shot out of your brain as you go. That's the right way to do a novel. You can't just wing it and make stuff up as you go as the story comes out of your mind. And it's almost like that's what needs to be done with these more complex orthodontic cases. You keep coming back to this whole idea of doing extremely thorough planning from the get-go and having discrete targets that you're trying to achieve based on a thorough plan that you determine from the beginning based on that patient's phenotype.
Yeah, especially like again, I'm not an expert with this, Ron, but I mean, I do think, like, as we move into this, like, when does the dentist or the orthodontist, like, stop expanding? Well, one way might be to use this 4-phase rhinomanometry to kind of know these patients that have this nasal resistance, how to measure them to know when to stop. Now, if they don't have nasal resistance or nasal flow problems, and you're just expanding them to correct their malocclusion, that may be a different matter. That's where I do think, kind of using that simulation software program like SureSmile, is very helpful. But if you're going to, now you have a patient that presents with a whole nother set of medical circumstances. Well, I think, you are a doctor, you kind of have to measure this stuff to make sure that you're doing right by your patient. And that takes time, that takes learning. It's a complete transformation of the orthodontic profession, but, they're in a position to really change dentistry and change healthcare for patients, and I mean, it's pretty amazing what they can do.
Yeah, you mentioned rhinomanometry, and my understanding of rhinomanometry is that it's basically a empirical way of testing someone's nasal breathing and the ability to determine whether they have resistance to their nasal breathing. Anil Rama, who is a very highly regarded sleep doctor at Stanford, taught me about rhinomanometry. But isn't that a hard thing to find? Like, that's not something you're going to get? Rhinomanometry testing is not something you're going to get at every dental office that you visit. Not even close.
No, you're not. Yeah, you're really going to have to seek out, special providers that have taken it upon themselves to really learn this and have this kind of passion for this field. It's very few and far between.
Mm-hmm. On the subject of interiorization, and you've mentioned now maxillofacial surgery a couple of times. I think a lot of patients, when they enter into the airway health space, orthodontic surgery is too much of a reach for them. It's like not in their paradigm, and they end up getting, I don't want to say lured in, but they end up settling for a MARPE and then whatever interiorization that they can get dentally.
Yeah.
Because they're just not ready to take the plunge into a $80,000 double jaw surgery that has a really difficult recovery, right? Now, if someone is getting those couple of millimeters of interiorization dentally via an SFOT or facilitated by an SFOT, is that a step backwards if they ultimately do decide to do a double jaw advancement? In other words, are you basically compensating those teeth through that process, and then you would have to bring those teeth back in order to get a maximum skeletal advancement surgically?
Again, obviously it depends on, are we advancing them for airway reasons? Are we advancing them not for airway reasons, but maybe just for dental facial harmony? You could be taking a step back. And that's why, again, Ron, I go back to the fact that you need this team. You need to kind of sit down with the orthodontist and say, okay, patients right now not going to go forward with this, but we're going to do anteriorization. And are we going to get to an acceptable compromise here? If the patient decides in a year or 5 or 10 to go into orthodontic surgery, what's the plan to decompensate them to do that? And are we going to be perhaps, kind of taking 2 steps, 1 step forward, 2 steps back if we go this direction? And that's just, I think, we're not dealing with cancer. We have to be able to kind of frame this to the patient so that we have an honest conversation with them about the compromises, the risks, the rewards, the potential future, opportunities or the future treatment if they so decide to do that, so that they're informed. And I think as long as we do that and we language it well and we're confident and we go through the planning, patient, can choose. And I think that's just an honest way of presenting it to the patient. And I think we have nothing but, high integrity with how we're planning. I mean, so to answer your question, yes, you could be taking 2 steps back. You may not be getting the advancement that you need, but the question is, why would you be getting the advancement? Do you need it for an airway reason? Do you need it for a facial balance reason, occlusion reason, etc.? Mm-hmm. But it's a lot to ask somebody to go through from a skeletal surgery standpoint. It's not inexpensive, and it's a lot. I also think that this is a big surgery, right? So you got to make sure that you're going to somebody who is pretty proficient in doing this. It's not like they do, 10 cases a year. That's my bias.
You're talking about MMA surgery?
Yes.
One of my Discord members wanted me to ask, who are your favorite maxillofacial surgeons?
I have worked with a number of docs. I would say Rob Relli is incredible. It's in Los Angeles. Mike Gunson, amazing. Reza Movahed, very talented. Brian Shaw and Steve Sullivan. Those are people that I have worked with. Dan Spagnoli. There's a great group out of Carolina. Brian Farrell, I think he's got an incredible reputation. Those are really, top-notch oral and maxillofacial surgeons. I have had the good fortune to work with Rob, to work with Reza, to work with Brian, Steve, Sullivan. They have all been magnanimous, very collaborative. They are understanding of the periodontal phenotype. They're very, interdisciplinary in nature, and they have just been, just incredible colleagues to work with. Mm-hmm. Stanley Liu, Casey Lee, another person I've had the good fortune to work with. I've had great experiences with these people.
Can SFOT be used not just as a complement to MARPE, but as a complement to a double jaw surgery? Is that ever a thing?
Absolutely. I have a patient that we had. This is a patient who had scoliosis and had idiopathic condylar resorption run, and just a wonderful young woman from Dallas. And she had, third molars. She had orthodontics on 3 different occasions. She ended up having fat pad grafts. And unfortunately, that actually worked quite well for a period of time, but her condyles continued to resorb. And it was almost like the condyles were like nothing. And we did a plan with Rick Robley. We did a MARPE. We did a double jaw SFOT because her roots were quite resorbed. So the idea was to decompensate her through a demineralized bone matrix, which the SFOT provided, so that we could do the tooth movement with a demineralized bone matrix, given the fact that she had root resorption. So we wanted to do that in the most gentle context possible. Rick used aligners, and then Steve Sullivan did an MMA on her and a total joint replacement for her. And I mean, you're talking about changing somebody's life. I mean, that was incredible. So, yes, in many of these cases where you have these thin phenotypes or you have these other idiosyncrasies, the SFOT can definitely be used not just to change the boundary conditions, but also to change the environment with which the teeth are being moved, so that you can negate some of these, these issues with root resorption and other things that you may come up against when you're trying to move teeth through cortical bone.
Mm-hmm. Are you often coordinating with maxillofacial surgeons who are doing segmental LaForts to get some expansion in addition to advancement for their patients? And they're coordinating with you to try to decide, and of course an orthodontist, to try to decide how much expansion they can do surgically and then hope to get the lower arch to match dentally after?
Yes, this is becoming more and more a focus. It's interesting, Ron. I have to say, historically, periodontics was completely left out of this conversation. It's always been orthodontist and the oral surgeon, and pretty much anybody else is kind of an afterthought. But now, with the advent of imaging, the simulation softwares, the more known facts of what SFOT can do, it's not just about moving teeth fast, like the Wilcodontics, kind of proposed, which is true. We can move the teeth more expeditiously for sure, but that's not the reason, right? We don't move we don't do this just to move teeth fast. That is a benefit. But I think what you're seeing now is that periodontist is being called in to do this because of all the nuances of doing the SFOT surgery. It really fits into the periodontal specialty very, very well in terms of mucogingival surgery, in terms of aesthetic crown lengthening, in terms of managing maybe small, periodontal defects and so forth. It really fits in well, but the periodontist needs to understand, how this fits into the big picture of the patient. What's the oral surgeon going to do to correct the dental facial disharmony? What's the orthodontist going to do to decompensate the dentition and this, the craniofacial skeleton to set them up for orthodontic surgery? And so this is not something that we're taught in residency programs. This is something you kind of have to learn to an extent on your own. And you have to take a step back to really kind of think through these things and really surround yourselves with good colleagues that are willing to share and teach. You're not threatening their livelihood. It's not like you're going to be taking implants from them or something. You're just trying to complement, what your skill set is and how you can complement their outcome. Mm-hmm. I think you're going to see more and more of that, these discussions evolve. Certainly these are things I'm having more and more with people. But, as the complexity of these cases, the more the more complex things become, so to speak, it's hard to work with more and more people, right? I mean, it's just like you kind of want to start to condense it because you realize, boy, I really have a skill set of working with these kinds of, these core team members. Mm-hmm. So
while we're on the subject of orthodontic surgery, I'm wondering your thoughts on other surgical modalities for expanding the mandible. One of them is MSDO, mandibular symphysial distraction. And then the other is something that is getting more and more attention these days, which is 5- and 6-piece mandibular surgeries, where the mandible is widened and advanced at the same time during orthodontic surgery. That's being done by people like Dr. David Bell, Dr. Sam Bobek, Dr. Shahid Aziz, Todd Hanna, and others are doing this these complex mandibular surgeries to widen and advance. What are your thoughts on surgical expansion of the mandible?
Ron, I don't have a lot of experience with that. I have worked with Dr. Bobek before. I found him to be a great surgeon, great person to work with. I guess just get a little concerned with like segmenting the mandible that much, depending on how far we're going. And I mean, that's a lot of hardware in there. And I mean, it would come back to like if we're doing that, great, if that's going to get a good outcome for the patient. But what is that going to what's the impact of all these plates and screws going to be on dental compensation? Like, are we going to decompensate teeth? Are we going to be limited now in terms of trying to decompensate the teeth? I mean, I guess that those would be things I would be kind of concerned with.
I mean, as a periodontist, tell us what happens around the arch when you have basically the whole thing lined with titanium plates. I mean, what does that do for long-term health of the gums and of the bone?
My preference would be to do the SFOT treatment first, line the teeth up, get everything optimized for that segmented mandible, if that's what needs to be done. Fine, no problem. Because when you go back and you try to now optimize the periodontal phenotype or the bone morphotype after the fact, you have a lot of scar tissue that you're dealing with. You have blood supply, that's been compromised. You have it's a more difficult field to work in. If you have teeth that are maybe compromised, and I mean, I don't mean to, I don't mean to be negative at all, Ron, but I mean, I have to tell you, in my opinion, it's the periodontist that has the skill set to really kind of to optimize like the prognosis of the teeth. So if we have teeth that maybe we're going to look to maybe put implants in or something, we're going to make decisions about retaining or not retaining teeth. I think it's the periodontist that has maybe is best positioned to make some of these decisions. And so now if you're going to lose teeth after the fact because they're resorbed or they develop resorption or something like that, and you have all these plates everywhere, I mean, the plates and the screws may be in positions where you want to have implants placed. Or if the plates are and screws are running and now you can't really move the teeth any further because you've got these segmented plates everywhere. I mean, that could be a problem.
Yeah. So the idea being that it's best to make sure that the teeth are in their final positions or close to their final positions prior to a surgery like that, because those plates can only get in the way later.
Yeah, and then do this. Yeah, optimize the decompensation, then do the skeletal, segmentation or surgery. Absolutely.
What about just removing the plates prior to doing those dental movements later? You certainly could. I know in Europe, obviously that's done quite a bit. They remove plates. And I think in this country, typically removing plates is not quite as common. So, I mean, I guess I don't know what Sam's perspective would be. I don't know if he goes back and takes the plates out or not. But, I think it's a really good conversation to have, and I think it demands the interdisciplinary approach on so many of these cases that we just need to kind of stop, put a pause, make sure we have the patient really kind of well cared for and evaluated, and then autopilot, right? And you got your action plan A, B, C, D. Everybody's kind of moving forward. Great, it's been well thought out. Mm-hmm. Mm-hmm. And thoughts on mandibular symphysial distraction? Are you bullish on that? Are you bearish on that? What are your thoughts on? I've been told that when you expand the mandible at the front, you can actually take the ramus and make that distance between this point and this point, which is considered desirable for aesthetics. You can actually narrow that because of the angle of the expansion. You're not really getting a lot of expansion at the molars. You're mostly getting expansion at the canines and toward the front, which can also be ugly. It's a sort of an unnatural way of making things bigger. It's not how things grow in nature. What are your thoughts on MSP?
Yeah, I don't know. I'm a little concerned with, I guess I would be a little hesitant with that. I have seen some incredible results from Reza Movad. He's done some, remarkable cases that I have seen. But I've also seen the fact that many of these patients are now coming back because of dental alveolar deficiencies, right? And now we see that they have these recession problems. And I think at the end of the day, if the patient, if the goal is to maintain their teeth with a good airway, with a good occlusion, with a good face, but if the goal is to like, hey, I want to have my teeth, we need to kind of evaluate what we're doing and what that impact might be on the periodontia.
So
I guess I'm optimistic but cautious.
Mm-hmm. So you worry about the effect on the health of the teeth and the periodontium with some of these distraction procedures?
Yes.
Specifically at the front?
Yes, because it's one of the most vulnerable areas. We don't have a lot of facial bone in the lower anterior. We have the mentalis muscle. We have constant muscle pressure and strain being put on the complex. These are the teeth that are oftentimes, compensated the most. These are the vulnerable areas.
Yeah, I had to have a gum graft on my lower anteriors because of just wear and tear.
Yeah, I'm not saying it's a negative thing. I'm not saying it's not a good thing to consider doing, but I would just want to make sure I scrutinize the impact of that on the tooth. And what better way to do that through simulation, software, and then that leads to cutting guides and other things that could even make you more precise and predictable.
Yeah. You this is a recurring theme in this interview is your emphasis on planning.
Yeah, that's really what it's all about. I think the person that's probably largely credited with ushering in like interdisciplinary dentistry is probably Dr. Mort Amsterdam, the iconic, legendary Dr. Amsterdam from the University of Pennsylvania, who ushered in the era of perio prosthesis when there were no implants. You're basically splitting teeth and doing mesobuccal, root amputations and all this stuff. And he used to say there may be many ways to treat disease, but there can only be but one correct diagnosis. And so, I think you really kind of have to think through the process of the patient, for the patient benefit. And that's really the most difficult, but it's also like the most interesting part of what we do. I mean, the older you get, it's like, it's wonderful to meet patients and be able to take care of our fellow man. But I mean, it's like a box of chocolates, right? Like you never know what you're going to get until you open up the box. Like, oh, this patient is much more compensated than I thought. This patient had a good face, but boy, they're actually a little bit class too. I mean, it's like, if you don't take the time to kind of think through all that, and then, then you're kind of, I don't know. To me, it's just you're doing a little bit of it. You're not doing what you could be doing.
Yeah. I want to ask you about periodontal concerns when planning a jaw surgery. Obviously, jaw surgery planning is extremely important. People mostly think in terms of movements of the bones, right? And how can we optimize function, TMJ health, airway, augmentation, and aesthetics all at the same time. I've talked about that with many people, many surgeons and many orthodontists. Feel free to chime in on what you think makes a good jaw surgery in the planning stage. But what I want to ask you about is the less sexy parts of planning a jaw surgery when it comes to dealing with decompensation, dental health, periodontal health. What do you think are the parts of jaw surgery planning that you really are, where you get involved as a periodontist that patients probably aren't thinking about ahead of time, and that some surgeons maybe just plow through those considerations and just go right to surgery without thinking about these dental and periodontal issues?
Yeah, like, do I have enough bone around my teeth to do the tooth movements safely before I come to do jaw surgery? Do I have good tissue thickness and volume after decompensation before I do jaw surgery so that I don't have periodontal problems 3, 5, 10 years after the fact? And one thing, Ron, is like, this is not necessarily from a patient perspective, but like from the doctors, like, is the vertical component in the condyles considered? Are my condyles seated well to do the jaw surgery, right? I mean, one thing to have the oral surgeon kind of putting the condyles in the right, the glenoid fossa correctly and then doing the surgery. But it's another if you kind of have the muscles relaxed, the visceral tissue relieved, and you have the condyles really seated well from splint therapy, so that vertical condition is really kind of correct, so that when they go to do the jaw surgery, they're not going to have a relapse. That, I think, is also quite important.
And managing that would be an interdisciplinary process that involves also presumably a prosthodontist or some sort of restorative dentist that can actually create that vertical thing permanently, because the splint can't be maintained forever.
No, yeah, maybe. Or an orthodontist that's kind of subscribes to the Roth, kind of style of orthodontics, is to kind of really pay attention to the condyle and the joint, make sure that is seated properly and there aren't any problems with cortication and condylar position. Those are obviously very important. And I think, look, by and large, the oral surgeons that I mentioned, these guys are, this is like second nature to them. These are things they're already thinking about. But others maybe not so much. I mean, so I think the things that I kind of tend to see, after the fact are these teeth that have these alveolo-skeletal discrepancies from the beginning. They're like, these vertical growers, Ron, where the teeth have really kind of stretched and now they've got root resorption because they were a high angle mandible to begin with. They were a vertical grower. We know that those patients start with less bone before orthodontic treatment decompensation. They end up with less bone, after orthodontic treatment. So they're already kind of a difficult case to begin with. these vertical growers, those are the ones that really kind of probably could benefit from the SFOT treatment to decompensate them and to transform their periodontal phenotype before they go to jaw surgery. Those are the ones that, they look great after orthodontic surgery. They have a beautiful airway, but they oftentimes, they're very subject and prone to root resorption or dental alveolar deficiencies now that, now we have more complex problems because if they're going to lose teeth, you're into a whole like kind of regeneration in order to provide them with any kind of implant options.
How can jaw surgery and the BSSO cuts, the LaForte cuts, can that actually do periodontal damage? And you mentioned that you can have periodontal loss after surgery. Is that what you're talking about?
Not so much like the BSSO, but like if you're doing the 3-piece maxilla and you don't have like the teeth separated enough, you make these cuts here. I mean, that could certainly cause periodontal compromises and significant bone loss. Many times these are more regenerative in nature because they're not they're not a disease process. Like periodontal, like native periodontal disease, that may be certainly more challenging. But a BSSO, not so much. It's really these high angle mandibles, these vertical growers that get decompensated, and you're just looking at things 2-dimensionally, and they go through this treatment, and years later they've got significant root resorption. They've got thin soft tissue, and over the course of their life, they're probably going to end up, losing teeth and maybe needing implants. If that's the case, maybe they develop, root resorption and so forth, or invasive cervical resorption. And now it's like, well, you're really faced with a significant horizontal and or vertical ridge augmentation needs to enable them to even become an implant candidate. So my question is, and again, this is a hypothetical, Ron, but could we have done the decompensation with bone augmentation, moved the teeth through a demineralized bone matrix, gotten a good functional matrix of bone around the teeth, optimized that, reduced the potential for root resorption, and had a better dental alveolar complex now? So if they did end up losing teeth for whatever reason, maybe we it's not this regenerative heroics to provide them with implants in the future. I guess that's a little hypothetical in nature, but these are things I think that really, need to be studied and questions that need to be asked. The imaging and what we see today allows us to kind of rethink some of these things.
Your emphasis on planning.
Yeah.
Does that inform a particular view you might have around the surgery first approach versus the orthodontics first approach?
I don't know enough about orthodontic surgery to maybe make these comments, but I would tell you, at first, without knowing more, I would not. I guess I would say I'm not necessarily a surgery first proponent because it doesn't allow. Essentially, unless you're letting everybody kind of participate in the plan, and then the team is like, yeah, surgery first. Okay, that makes sense. But if you're just the surgeon saying, you don't need orthodontics, we're just going to do surgery first, usually that leads to problems. At least that's what I've seen. Relapse, now you need orthodontics that is more complicated. You need periodontal intervention. This stuff wasn't really kind of discussed with the patient from the beginning. Now an $80,000 surgery ends up becoming $200,000 for the patient. They maybe lose teeth. They weren't, maybe they need orthodontics again. It just becomes kind of, I think in the patient's mind, if I was a patient, and it was surgery first, at least it would be, well, I did see everybody. The team made this decision for me, and this was the right goal, because there's all these checks and balances rather than one person being the judge and jury.
And what characteristics would a patient have to meet to be a safe surgery first candidate? Like if they had a team, what boxes would be checked? for them to be able to go into surgery tomorrow before any orthodontic work were done?
Perio-wise, hygiene is good. They've got good keratinized tissue. They've got teeth that are actually inclined into the, optimally. They've got good bone around the teeth. There's no disease. They have significant sleep apnea. It's jeopardizing their quality of life, and so kind of moving them forward is the most important thing for their quality of life and their systemic health. I definitely would buy that. So I think these things that I would be looking at would be, the patient's got a good oral hygiene. The patient's is free of any dental disease, any periodontal disease. The patient has good periodontal phenotype characteristics that are unlikely need to be managed or corrected even post-surgery, or if they need to be corrected post-surgery, that can be done very predictably, and then move them forward to orthodontics.
Where do you fall in the debate around in a jaw surgery do you err on the side of maximizing airway with the biggest possible advancement, or are you more of, let's meet somewhere halfway in order to get a better aesthetic outcome that doesn't look too much like a dog after you do a big advancement on a patient?
Complex question, Ron. You have good questions, actually. Good questions. I think at the end of the day, because of the nature of what we do, patients don't necessarily want to look like they're from the planet of the apes. I think they would probably want to look. I would be more on the side of having the patient look aesthetically as pleasing as possible without looking so overly brought forward. Now, that being said, if you have a patient who has really severe OSA, that is a patient that's, again, probably is going to need to be brought significantly more forward than somebody that just has a dental facial disharmony that doesn't have airway problems. Depends on how much they're suffering. I think you have this, like the older truck driver probably doesn't care much about aesthetics, but doesn't care about it until it happens. And then when it happens and he's not happy the way he looks or she looks, that's a problem. So again, going back to the planning, but I'd probably be somewhere in the middle. My initial reaction would be probably more err on optimizing aesthetics, and then you're gonna benefit from an airway standpoint to a degree for sure. But if you really kind of mess up the aesthetics on a patient, that is, that's there for everybody to see. And that psychologically could really kind of could really impact somebody's quality of life for all these other reasons. Maybe they would be okay with, coming forward and then using CPAP if that's a reasonable way to, if they're measured properly and they're doing okay. I guess just that's probably where I would fall with that question.
Before I leave the MARPE topic completely, I wanted to ask you another question from my Discord server. Can SFOT be done on the inside of the arch in order to, in a MARPE overexpansion case, in order to help bring the upper teeth back in rather than the lower teeth back out?
Yes, absolutely. So oftentimes people talk about doing the SFOT on just the buccal or buccal and lingual. And so what you need to understand is the SFOT procedure is creating this demineralized bone matrix around the teeth, or this regional accelerator phenomena, which lasts for about 3, maybe 4 months or so. And if you're going to be expanding and you're going to be really moving the teeth out, the bone augmentation is probably going to be needed. But if you're doing what you're talking about and kind of bringing them in, you may just need to do the corticotomies, dental alveolar decortication, to stimulate the rat phenomena to enable the teeth to be moved more expeditiously to the palate. And a lot of times in the palate, what we'll find palatal tori on the palatal surfaces of like the first and second molars. And that can impact tongue space. So by removing a lot of those palatal tori, I'm not talking about right in the center of the roof of the mouth. I'm talking about kind of around the molars, kind of removing those tori, creating that wrap phenomena, maybe putting a very mild, very limited amount of bone around the teeth so that they don't, they have some regeneration. I think that would be very, very reasonable, and it may create more tongue space for a patient.
Mm-hmm. But inherently on the lingual side, there's less need to actually place bone grafting material because there more bone already there generally?
Well, not so much that there's more bone. Yes, there is. And again, you need to look at the imaging to determine, and you have to understand how the teeth are moving. But on the palate, all we have is attached gingiva. So the likelihood of creating recession-based problems is reduced on the palate because all you have is attached gingiva. So you have nothing but bound down tissue in that area. It's like less vulnerable, I would say.
But what are the teeth going to reside in once you migrate them lingually?
Yeah. So if you don't have enough bone to kind of move the teeth where they want to end up, then you will need to bone graft. But you may not. Let's say you end up with a dehiscence defect on a tooth, on the palate. You may not really notice that unless you image or do a exploratory flap surgery or something like that, because the ramifications, you may not develop recession because you've got nothing but attached, robust, bound down tissue on the palate. Mm-hmm. So it may not be quite as vulnerable as what we experience on the buccal. There's just no mucosa on the palate. Mm-hmm. So the attachment apparatus is maybe a little less, more resistant to these recession-based problems. Mm-hmm. But still not, you still probably would graft. Not as much.
Right. Could you just explain SFOT and what's involved in SFOT as you would to a total newbie?
Sure. So basically, the surgical operation is going to be dependent on an orthodontic decompensation plan. So depending on, how the orthodontist is going to move the teeth, we're going to work together. And basically the surgery is done under profound local anesthesia. It's mostly done, at least in the way we do it, is we either do it with IV conscious sedation, or we do it preferably with more advanced anesthesia, deep sedation or intubated general anesthesia with our dental anesthesia colleagues. So I have a separate person kind of managing that. The first thing that I do after profound local anesthesia is we do our flap surgery, and the flap surgery is done with incisions, like when you're probing the gum tissues, either sulcular incisions or scalloped incisions. The first thing that I'm going to do is say, okay, does the patient have any altered active or passive eruption patterns? In other words, is the clinical crown length of the teeth correct, or do I need to move the crestal bone back so that the full clinical crown length of the teeth are exposed? Many times you'll see patients with very short teeth. It's basically just because the teeth haven't erupted properly. The dental gingival complex is not in the correct position. So part of the surgery will involve aesthetic crown enhancement. So we open the flaps judiciously, very carefully, and I think that's one of the things that periodontics really brings to the table is we really, we're very careful with opening and closing, and that's really the key. So judicious flap opening. We then look at the crestal bone levels and determine, do we need to do any aesthetic crown lengthening anywhere? Is there any root surface accretions around the teeth? Are there any cervical enamel projections? Are there any anomalies that need to be kind of managed, around the teeth? Once that's done, then we move into the corticotomies and the dental-alveolar decortication. So the corticotomies are the vertical slits in between the teeth, and that's what simulates fracture healing. So the corticotomies are done buccal or buccal and lingual. If you do buccal and lingual, you get a bigger demineralization phenomena all the way around the teeth, which helps expedite the tooth movement. So depending on how far the orthodontist needs to move the teeth, you may consider doing it buccal and lingual. But the corticotomies are then done interdentally between the teeth, and then they're generally connected at least 5 millimeters below the apices of the teeth so that we don't sever pulpal blood supply. If many times you'll have a dehiscence defect or a fenestration, in which case you would not do any dental-alveolar decortication because there is no bone there to decorticate. But in cases where there are, then we basically make these little dots to create this regional acceleratory phenomena, this demineralization on the buccal and lingual sides of the teeth. So you're kind of simulating this injury to the buccal and lingual of the teeth, and that is known as your dental-alveolar decortication. From there, we go ahead and do our particular bone grafting. So my preference is when I have a dehisced root surface or a fenestrated root surface, or at the end of the day, I really want a regeneration result. So I want to have bone, periodontal ligament, and cementum. I will generally use, I'll generally use cancellous allograft. And I use cancellous allograft up against the root surfaces of the teeth because that tends to resorb quickly and it encourages periodontal regeneration. And then beyond that, we would use a cortical cancellous allograft and maybe a BioOs or xenograft mix. That tends to resorb more slowly and helps to maintain a good functional matrix around the teeth. So once all that gets incorporated, the volume is very maintainable over the long term. So oftentimes we're drawing platelet-rich fibrin out of venipuncture. So we'll create what's called sticky bone. So the bone is kind of more teased around the teeth. And then my preference, and not everybody subscribes to this, but my preference is to use like a collagen membrane to stabilize that graft and usually tack it in two places, because when you go to replace the flaps and you dissect the flaps and you want to kind of move the tissue back around the neck of the tooth, if that bone graft moves at all, then you're going to have a compromise in terms of the outcome. The key of the bone graft is these PASS principles, which means passive wound closure, angiogenesis, wound stabilization, and space maintenance. So I like to use a collagen membrane. It's usually a BioGuide membrane. Stabilizes the graft. We then kind of lift the flaps and dissect and passively suture them around the neck of the tooth, so that when everything is sutured, we have the correct clinical crown length of the teeth, and then we have a passive flap adaptation around the teeth.
Mm-hmm. Mm-hmm. Now, tell me about differences between various SFOT providers around the world and around the country. I've seen patients that have had supposedly an SFOT done, but instead of the flapping occurring at the gum line, the flapping is happening up here.
Yeah.
Where the lips or the cheeks meet the top of the gums. Is that an inferior way of doing it? Why do you do it at the gum line instead? You've already hinted at some other things like getting the height of the teeth right, for example, and fixing other issues that appear at the gum line. But what are your thoughts on that different location for opening the patient up?
Yeah, it could be a blood supply issue or whatnot, but like you're talking about it as a vestibular approach, that could be a reasonable approach. I haven't found a whole lot of reasons to do it in a vestibular approach. I also haven't found a lot of opportunity to do it in a kind of a closed approach, or these kind of making little vertical incisions and kind of packing bone in that area. And that is partly because, one of the tenets of surgery is visualization, access and visualization. So I do like to kind of have access. I like to see what I'm doing. And the more closed approach, some of these procedures can become, maybe the less likelihood you can kind of get the bone graft put in exactly where you want it to be. Now, with some of these soft tissue grafting procedures, certainly minimally invasive tunneling procedures are reasonable. And oftentimes we need to do soft tissue augmentation before we do the bone morphotype surgery, because you could get flap dehiscence, you could get a perforation. You just don't have a good overall, like a canvas with which to do the bone augmentation surgery. So sometimes you need to kind of augment the soft tissue first and then come back 12 weeks later and then do the bone augmentation. But I think using a vestibular approach, depending on the circumstance, maybe a more localized procedure, maybe you have a compromise in blood supply, maybe you already have the crown lengthening is not needed. I think it would be more of a unique situation than a more common situation, Ron. I also think that in terms of the materials, like, in Europe, they pretty much just use a xenograft. That's a very slowly resorbing product, which we do use, but I don't use a ton of it in the matrix. I tend to use a lesser amount. It's mainly so that when it does get incorporated, it maintains its volume long term. And this comes from most of the sinus augmentation literature that's out there showing it's effective for bone growth, but it's also very substantive. It maintains itself a long time. And essentially bone grows around the particles. It doesn't really replace it. It's not like a replacement resorption that's happening as with the allograft. So in this country, you'll see most providers using an allograft type of matrix.
And are you incorporating any autografting into the mix by like scraping some bone dust off of the patient's bone while you're operating to help with presumably the body accepting the graft?
No, not around the teeth, because there have been some literature showing that, putting autogenous bone against the root surfaces of the teeth can induce root resorption. So I don't typically do that. But interestingly enough, because of the myriad of things that with these comprehensive treatment plans, many patients are also undergoing orthodontic treatment. They need to be decompensated. They may need the dental gingival complex to be put in the right position. They may need to have some connective tissue grafting done simultaneous with the SFOT. So using the BioGuide membranes, you can do interpositional connective tissue grafts along with the SFOT. And invariably, if somebody's missing teeth, you may be doing some site development simultaneous for future implants, simultaneous with the SFOT procedure. So in that situation where there's an edentulous ridge, that's where I would probably be using the autograft.
Mm-hmm. Mm-hmm. Do you find that a lot of that you struggle to get people to connect with what you do because of how technical this stuff is as compared to, say, orthodontics or even maxillofacial surgery, where we're basically talking about mechanics rather than biochemistry?
Sometimes, sometimes it's a bit overwhelming for patients. I think that videos are very helpful. We have some videos to show patients. They're like animated cartoons, so that's helpful and they're not scary. The other thing, again, you go back to the SureSmile, and I'm oftentimes able to reinforce the orthodontic plan that has been put forth, and I can kind of show the patient, this is why we're doing the procedure, because you just don't have the bone volume to do this orthodontic treatment safely. So, so trying to be, good and transparent in terms of languaging it, but also not being, so technical that, people are going to get turned off.
Yeah, it just strikes me. It just strikes me that, of course, it's definitely a fine line. It strikes me that this is the least accessible part of Airway, the Airway health space in the orthodontic, maxillofacial, jaw hacking space, is the periodontal side. I think as soon as people start hearing all the jargon, their brain just shuts off, and they would rather just think in terms of transverse, forward, rotation, and instead we're talking about, allografts, xenografts, autografts, so on and so forth, and all of this anatomy around the periodontium. And I think that because it's so inaccessible to the layman, that it ends up being neglected because it's not something they can easily wrap their heads around or get involved in their own treatment planning around it. Because, my audience loves to be involved in their treatment planning. And I think this stuff is just outside of their league. It's outside of my league. And that's really what I'm saying, is that I have a hard time keeping up with everything you're saying. And I'm sure my audience is too, unless they're pausing the video, taking notes, and using ChatGPT to figure it all out. But yeah,
sometimes there's a growth factor. I don't even get into growth factors and all that stuff. Honestly, I'm hoping that going through the consultation process and the planning process, Ron, we're oftentimes, we feel compelled to have all the answers in a 30 or a 60-minute consultation with somebody. And that's just not going to happen. I want to use the hour-and-a-half consultation that I have with somebody with this type of treatment as a data gathering appointment, period. And a big picture and then I will have them back to kind of go over the scope of the plan and the rationale and so forth. But there has to be a level of trust and confidence, and the patients they want to know we can take a deep dive, but really they just need to know that we're going to take good care of you. We're going to get bone around your teeth so we can execute this plan, because human anatomy is such that, we have thin bone around our teeth, and it's the advent of imaging that we have in all our offices today that has allowed us to appreciate this limitation and be able to treatment plan better, so that we have a better transverse, more robust. So when you're done, your teeth are centered in bone and they're not going to have periodontal problems.
Yeah. A question about my own case. I'm strongly considering doing an MMA surgery after 8 years of mixed results with various expanders and orthodontics. And I've consulted with several surgeons, Dr. Gunson, Dr. Wallin, Dr. Bell, and Dr. Alfie. I definitely need a significant amount of orthodontics again prior to my surgery, partly to undo some of the work that's already been done in terms of compensating me, because I didn't plan on doing a jaw surgery, right? And around my MARPE especially, where to get my bite back after MARPE, some of my teeth had to be really tipped in. And so the roots of those teeth are sort of almost on their way out of the bone. And then on the other side, I have a crossbite still, even after my MARPE. And just, you can imagine 8 years of wear and tear. The situation is not looking pretty. I should probably consider SFOT if I'm doing another year of orthodontics to prepare for surgery. Is that fair? It's something I should look at, isn't it?
I think it's something you should consider, particularly after all the years that you've been through. The question would be, incidence of root resorption. Can we get a little bit further with dental alveolar augmentation, and can we optimize conditions so that you have the best result from an orthodontic standpoint? But it's interesting. Looking at you, you don't look like. That's what's so interesting about doing the treatment planning is, you have a nice face. It doesn't look to me like you're deficient. And that's where, if you don't spend the time and not just analyzing the patient from a facial perspective, but also periodontal perspective, looking at the imaging, how I always ask the question, unless somebody comes in with like a Brad Pitt or somebody like this who's got a perfect face, which is like almost nobody, they're compensating to some extent. So how significant are these compensations, and what are the compensations? And then what do we need to do to reverse them to get them the best result? That's what I'm thinking initially, because most patients have some level of compensation.
Yeah. And I know you haven't seen the data of my case, but some potential reasons I would do SFOT would be so that when I was moving those teeth as part of my pre-surgical orthodontics, there's just less root resorption because of the wrap effect, facilitating the bodily movement of those teeth with less collateral damage, so to speak.
Right.
but then also to buffer the areas with more bone for later after the surgery's done.
Correct.
Is that right?
That's exactly right. Yeah, to get a better neuromos phenotype. And the people you consulted with, Dr. Alfie, Wallin, I mean, these are all pretty much top of the heap. These are excellent people to be working with.
Yeah, I'm not messing around.
No, Gunson, I mean, you're talking the best of the best.
Yeah. Dr. Bell is fantastic too. He's kind of new on the scene because he's new to private practice, but he's doing some things that not a lot of other people are doing. He's also just.
Are you talking about in Oregon?
No, he's in Newport Beach, California.
Oh, okay.
Yes. He's also just a dear friend and extremely empathetic person who has spent hours and hours looking at my case and giving me insights. So then what should a patient look for in a competent SFOT provider? I just mentioned some of the top jaw surgeons in the country and in the world. And really, when you get into the jaw surgery space, you realize that when you hit the boundaries of that space, there really aren't that many people doing only orthodontic surgery. There's maybe, I don't know, just throw a number out there, 20 or 30 people in the world that you might trust to operate on your child or on yourself.
Right.
Is that what it's like with SFOT providers? I mean, I know probably 10x fewer SFOT providers than I do maxillofacial surgeons who I would trust for orthodontic surgery. How small really is the pool of competent SFOT providers, and what do you look for when vetting an SFOT provider?
Well, I would like to think most of us as periodontists can do this and do this well. We're pretty well trained, but this is a little bit of a subspecialty, so to speak. For me, it's been something that I have learned over many years, and I've kind of learned from, essentially being able to learn from some of the best oral surgeons, and then couple that with some of the best periodontists. So, like, kind of learning how to like open flaps and do bone surgery, but then also at the same time how to be finesse and how to be very careful and suture properly, like a periodont. So it's kind of a blend of the two, and there really isn't a lot of places to learn or train to do this. The Wilcos used to teach this type of a course, but it was more of a show and tell. It really wasn't like the details and how to do it, and it was more about moving teeth fast. It really wasn't about considering airway and considering phenotype. These are all things that have kind of happened later.
Can I just interrupt briefly to get into the history of this stuff? You've mentioned the Wilco brothers a couple of times now. Yeah. So this accelerated orthodontics treatment, this periodontal treatment to make orthodontics go faster and with less collateral damage, was that invented by the Wilco brothers? And what really distinguishes SFOT from Wilcodontics? Are they putting less grafting in because there's not as much of an expansion component to it? Are they just mostly doing the corticotomies, or is it really just the same procedure, but it's the orthodontic planning that's different? We talk about SFOT versus Wilcodontics.
Yeah, so SFOT, this acronym, Surgically Facilitated Orthodontic Therapy, was coined by Rick Rowley. To give you a historical perspective, this is crazy, but I found that the first kind of report of the interdental corticotomy was actually like in 1895 or something. It was in a Journal of Oral Surgery published in 1976, somebody talking about the interdental corticotomy at this dental congress in Chicago. I don't even know if we had an aesthetic back then, Ron. I don't know, but
whiskey.
And then you talked about there were people in Europe, Kohnstock, Bischelmeyer, other people that were reporting on kind of a type of dental alveolar tooth movement to help facilitate maxillary protrusion. So they would have these patients whose teeth were like this, and they would basically do what looked like corticotomies. Essentially what they were doing is they were removing resistance to tooth movement. They were doing these kind of corticotomies, and then they would put removable appliances in and move the teeth back, so somebody wasn't so buck-toothed, if you will. And essentially that's what they were doing, but they really didn't realize what they were doing. Move fast forward you have, and the reason I was asking about Bell is because Dr. Bell, a legendary oral surgeon, was the first one to show in rhesus monkeys that you could do a LaForte osteotomy, and if you could maintain the blood supply to the maxilla if you didn't remove the mucoperiostome periosteum on the palate. So Bob Bell showed that this was, a real thing. And his son is I think a microvascular guy in Oregon, but then came along Bob Schallhorn, and Bob Schallhorn was one of our legendary periodontists, and he showed doing autogenous bone grafting, believe it or not, or using hip marrow for periodontal defects. So he was the first one to show that bone grafting around teeth would actually work. Now you kind of move into the Wilcos, and the Wilcos essentially kind of exploited a lot of that history, but they were showing, this brother team, they were showing how the teeth were moving very quickly. What was really remarkable about them is that they were the ones to really describe the reason for the tooth movement. They were the ones to show that it was this coupled demineralization, remineralization phenomena that was happening around the teeth.
The wrap phenomenon.
Yeah. Well, the wrap phenomenon was described by this guy named Dr. Frost out of Henry Ford Hospital. He was an orthopedic surgeon studying fracture healing, and he basically described wrap. And so they used that, and they kind of talked about this remineralization, demineralization phenomena that was happening, because much of us that learned how to orthodontics in the 90s, it was pressure tension mechanics. So you push on a tooth, bone has to resorb, and then it has to deposit on the other side. We never, it wasn't conceived to us that, if you do this surgery and you create this wrap phenomena, that the tooth moves the bone moves like a shield, right? So here's the bone, the tooth and the bone are moving together. They're not moving tooth isn't cutting through it. So they were the ones to kind of show that, but they took that and then they tried to popularize it on moving teeth fast. And, the profession got or at least the orthodontic profession got, kind of chapped about that, because it was why are we moving teeth fast? You're going to put somebody through all this surgery to just to move teeth fast? I mean, why would we do that? But most of us didn't have imaging in our offices to realize the bone volume that was being created around the teeth, the phenotype that was being created. And while they did do a lot of publishing, it was not with this airway concept. So now all these things come to fruition where, we want to expand arches. We want to have a better broad smile like Tiger Woods, have a, nice broad corridor of teeth, but we don't want to do that at the sacrifice of the periodontium. And if we can make the patient's airway better, hey, that's awesome. So that's got a little bit of a kind of a history. And now, with the American Academy of Periodontology, we've published on a few best evidence consensus papers now showing the importance of doing imaging or interdisciplinary treatment planning, and also the opportunities for phenotype modification therapy. But even with all that literature around, there isn't a lot of high level evidence to, there's just not a lot of studies long term, looking at this stuff, which I wish there was. Mm-hmm. And then what's the impact of all this on the airway, right? Nobody's really kind of measuring. Here's how patient begins. They have a transverse problem. They go through this, and then their outcome at 5 and 10 years is X. Now their RDIs are better. They're maintained. They're da-da-da-da. So it's just still kind of intuitive to a degree, but that's the history of this.
So SFOT kind of found its home in airway focused orthodontics because the accelerated orthodontics was not enough of a sell to get orthodontists on board to buy into it, because they were like, hey, who cares about all that speed if it involves this expensive, painful surgery that you have to pitch to a patient? But if you can also get not only speed, but this opportunity to really augment the arches and minimize collateral damage by, reducing the amount of root resorption because there's less resistance to the movement. Now we're adding some additional value proposition on top of just speed.
Yeah. So it was this patchwork quilt, of understanding, hey, the imaging studies show us that normal human anatomy is 1 millimeter of facial bone thickness. That's normal. And many patients have less than 1 millimeter of facial bone thickness in the anterior periodontium. Well, now we want to couple that with we want to expand patients. We want to expand their arches. Hey, there's not enough bone to do that. So this phenotype modification can augment the periodontium to improve periodontal parameters to allow that to happen. And by the way, because it involves the surgery, it does create a faster tooth movement. And, so it's kind of like you have to tie all these loose ends together. You have to kind of connect all these dots.
And you mentioned that Dr. Rick Robley, who's an orthodontist, by the way, coined the term SFOT. Now, I know he works alongside with the periodontist, excuse me, Dr. Mike Curry, also there in Northwest Arkansas. Did he put Curry onto this as a way of making his orthodontic practice more robust, or was Curry already doing SFOT and then him and Robley just teamed up? I guess what I'm asking is, was Robley the big catalyst for the Curry-Robley team adopting this SFOT modality? Yeah, they're
incredible. Rick is he's an amazing orthodontist, and Mike is just a dear friend and an incredible periodontist. So initially, when this all was kind of taking stride, it really was Rick Robley and Scotty Bolding. Scotty Bolding was the oral maxillofacial surgeon that he was working with to do most of the SFOT treatment, which also involved dental alveolar distraction treatment, right? So not only were they doing coracotomies, they were also doing distraction osteogenesis as well with some of their cases. And that's what was published early on. So the early papers in compendium were actually Robley and Bolding. And for whatever reason, I don't know if Dr. Bolding, I think he's now in Florida, but Dr. Curry was a local periodontist and was probably already working with Dr. Robley. So when he moved there, he had an opportunity to kind of fill that void, and Mike has done so, in just incredible form.
What do you mean that Scotty Bolding and Robley were doing distraction osteogenesis along with the SFOT?
So they would show cases where they would actually do distraction surgery. So for instance, let's say you have an ankylosed tooth, or you have an implant, right? And you can't move that with orthodontic treatment. So you actually have to cut a block out and then do a little green stick fracture and then hold it till you get a clot, and then you start to distract that segment. So Scotty would basically do a block section, hold it, and then they would distract the segment. So he would do the distraction osteogenesis on some of the earlier cases.
Is that what it takes to move an implant if you're doing orthodontics on someone who has dental implants?
Yeah, you cannot move an implant. You're not moving an implant.
So you have to block it out and then move the whole block?
Yeah, so if you think about the orthodontic principles, right? If you keep the palatal blood supply, you don't injure that. And then you basically cut a block that, and you create a wedge, you create a block section, and you free up that section. You do a little green stick fracture, and then you hold it for a couple of days, and you get the clot to stabilize. Then the orthodontist can slowly move that segment down, and it's moving through a distraction histiogenesis. So it's not moving through this wrap phenomena. You've got the whole bone segment that's kind of moving down. And I've actually done that on some ankylosed central incisors, where we actually did a distraction osteogenesis around the central incisors, brought the whole segment down so the patient could, keep their teeth.
For a anterior open bite, from a thumb sucker?
No, somebody got in an accident and they injured their teeth and their teeth became ankylosed. And then as they grew, everything, kind of grew normally, but these teeth were like implants, and they were just the segment was impacted. It almost looked like it was impacted. So we did a distraction surgery, and we're able to kind of move that segment down.
Wow, man, that's wild.
Yeah,
stuff is just it's a whole different angle to think about.
But that's the history with with Rick is largely credited with, early on, the Wilcos, they didn't want, and they had their Wilcodontics patented and copyrighted and all this stuff, and they're very territorial and just very, while we wouldn't be here without them today, they weren't as
open source,
collegial, and kind of like, unless you took their course, this kind of thing,
Yeah.
And then when you did, it was like, you really couldn't teach it. It was like they had the patent on everything. So it wasn't, Rick kind of said, okay, well, I'll just coin it a different term, right? And he created that term, and, he and Mike have done some amazing work together.
Mm-hmm. Did you have any other thoughts on vetting SFOT providers, patients out there?
Yeah, I would look for like, how many cases have you done? Have you published anything? What orthodontists do you work with? What are do you have any long-term outcomes? Do you have a surgical environment with which you, like, am I just going to be numb, or do you use advanced anesthesia? I find that using advanced anesthesia really allows you to control all the circumstances so that you can operate at your best, because many patients, are highly nervous and anxious about these procedures. And sometimes, moderate sedation is not going to cut it to create an environment so that they're calm, they're relaxed, and you can really bring out the best skill set in yourself. So that would be one thing I would also look at, like what are the sterility conditions I'm going to be, is this like an operating room, or am I working out of like a dental cubicle, right? It's not kind of how I would want to be treated. Do you have any patients I could talk to? But I think those are mainly like, have you done, how many cases have you done? Can you show me some examples? Have you published anything? What orthodontists do you work with? And those are probably some good starting questions to begin with.
How does one even learn to do SFOT? I know you have a course that you teach. Are there other courses like that? I've never heard of any other courses besides yours.
Historically there was the Wilco course, but that was it was a 2-day lecture course. It was like a show and tell, which was great. I think Mike and Rick have a course. I don't know what is involved in all that course, but I'm sure it's excellent. Todd Shire has a course that he gives. He's another. So I would say like Todd Shire, Mike McGuire, Todd Shire, Mike Curry, me, are probably the people that do the most of this. Todd is in Houston. He has a course called Beyond Perio Ortho Limits that he teaches with David Alfie and John Krotkin. They have a really good team there. Mariana Evans, obviously Rebecca Backow, they're incredible. But I do have a course that is focused basically on the technique of it, the procedure. So we'll go through like the biology and everything that we talked about a little bit today, but I'm going to kind of walk through like all the little steps that we do, and then show 2 or 3 would have like live surgery demonstrations. So it's a smaller course, and it's aimed at more of a surgical kind of colleagues, and really just kind of sharing like how I do the procedure. I've done a lot of it. I've published a book. I've done it, over the last 15, 20 years, I've done a lot, and it's just showing like, not that I'm the end all be all, but basically this is kind of how I look at things. This is the environment that we do it. This is the workup process, and just to get people kind of comfortable and a way to, to learn like I did. I was fortunate enough to learn from Rick. I was fortunate enough to learn from Dan Spagnoli, and in a kind of like a patchwork quilt of just learning from a lot of different people, and then kind of bringing it into my concepts and ideas to benefit patients.
And does your course also have an Airway leaning to it? It
does, yeah. Ellen Crean will be doing the course with me. Ellen is a DDS PhD. She's a tremendous, this is somebody you should have on the podcast. She's a tremendous resource for somebody who wants to develop an airway-focused practice. She had many facial pain clinics in the southwest corner of the U.S. She has a PhD in biology, neuroscience. She's on the orthodontic faculty at Midwest or AT Still in Arizona. And she's the one that brought the 4-phase rhinomanometry to me and to the Chicagoland area. She's been an incredible resource. So we're going to be looking at things like, okay, how do you look at the structure, function, and behavior? Like, these are the core things that we look at. And then how do we tie this into a plan so that we have a measured result for patients? And then, of course, okay, here's how we do the coracotomy surgery as a part of that plan.
Mm-hmm. Mm-hmm. Yeah, fantastic. And how can people access your course? When is the next course offering?
It's April 25th and 26th. It's in Glenview. And then
Glenview, where's
Illinois, yeah. It's Chicago. It's basically like 10, 15 minutes from O'Hare. So it's a very quick cab ride or Uber from O'Hare. There's multiple hotels right in the area. But I guess I could send you a link or something like that to the course.
Yeah, I'll drop a link in the description of this video.
Sure. But that would be the best way to do it. And then depending on how well it's received, we may do one in the fall. I mean, the goal is just to kind of share the science, to share the biology, and then to show people, like, just to show how I do the procedure. And hopefully that will give them the confidence to then go back and say, okay, I saw how we did this, how the little nuances here and there. And hopefully that'll give them the impetus to start doing it in their practice, because we have to have more people, providing this service, and there has to be an education source to do that. So hopefully I'll learn from the students, they'll learn from me, and we can create an even better course the next time.
And is this periodontists only would be candidates for this course, or general dentists and orthodontists welcome as well? Yeah,
general dentists, orthodontists. I mean, I don't know how many orthodontists are going to want to take a technique course on the surgery, but if they want to, they're welcome to come. Oral surgeons are welcome to come. I'm not really kind of holding it out to a particular specialty, but I would like it to be done by whomever it's being done by at a certain level. That would be my goal.
Mm-hmm. And will there be a digital version of the course that's available? Or is it in person only?
Is being recorded?
Yeah.
I don't think so. Not at this point. I don't think so. If it's like a 2-day, I don't think so. But
is it a hands-on course?
It's a live surgery course, so they can come in. So I have a camera in the operating room, and we'll be streaming the surgery from the OR to the education center, which is just down the hallway. But at the same time, people can come and look over the shoulder as well. So trying to make it as clear and as transparent as I can. I've not found, like, if you're dealing with a group of people that do a lot of surgery, I don't know how helpful it is to have like a pig jaw or something like that, which isn't really real.
Yeah.
Yeah.
They all know probably the basic mechanics around the surgery.
Pretty much. They just want to see, okay, what material instruments are you using? How far are you reflecting a flap? Like all the little nuances that they're going to be able to see by witnessing the procedures.
Mm-hmm. Fantastic. That course sounds like a great opportunity. I wish I could be there, just as a journalist and as an enthusiastic researcher. So I think it's a great opportunity for anyone who wants to learn more about this. It's obviously an extremely technical subject matter. And so I'll drop a link to that course in the description of this video. We're almost at 2 hours. Do you have time for a couple more questions, Doctor?
Sure.
When I interviewed Rebecca Bachau some years ago now, she had expressed to me that she was sort of falling out of love with SFOT because she felt that it was a lot of flaring that was happening, but not a lot of bodily movement of the teeth. And then she also suggested that the results weren't that stable. I know she went through the OrthoPerio program at Penn, along with Mariana Evans and some other prominent Airway orthodontists that the audience has probably heard of before. To what degree is the tooth movement that happens with SFOT to what extent is it bodily movement versus just tipping? And can you comment on the stability of the results that you get with SFOT and how that's managed?
Yeah. So you really have to be attentive with where you need to demineralize the bone matrix for the tooth to move bodily, right? It's much easier to demineralize tooth root at the coronal 1/3 than it is the apical 1/3, because that's where the bone is really thick. That's where you really need to kind of get in and demineralize that and cut the bone down so the tooth can kind of move, right? So it's a lot of technical nuances, again, that I'm getting into. But you know, and there's nothing really studied or measured here, but I would say, you know, in terms of the results being stable, I would tend to dispute that, because in the literature, the Wilcos have shown through using what's called the Mandibular Irregularity Index that the incidence of orthodontic relapse is clearly less when you do corticotomy surgery and bone grafting compared to not doing the surgery at all. I mean, that's vetted, that's in the literature. So I would tend to dispute that, you know, and I'm disputing it with evidence. I would say, you know, in terms of the translation of the teeth, depends on, you know, the orthodontist really kind of getting on the regional acceleratory phenomena, really kind of getting the heavy orthodontic mechanics done during this window of opportunity. And also the surgeon really kind of getting that bone demineralized in all the areas where they need to, so that we can kind of upright the tooth and get it as translated as best as possible.
Mm-hmm. And on that note, I find that orthodontists are generally using Invisalign to accomplish the tooth movements following SFOT.
Yeah.
Is that the system you recommend? Can braces be used? What about just expanders like this sort of thing, to be used to just blow the teeth out with SFOT, especially on the lower? Talk about tooth moving systems following SFOT during that critical window.
I mean, I think Invisalign is certainly a reasonable option. I would probably, if I had my choice, I'd rather have, you know, good old fashioned brackets and a heavy arch wire in there, because I think there's a lot more control from an orthodontic perspective that can be gained. I think that you also don't have plastic in between the teeth. I think, you know, just from an occlusion standpoint and maybe even getting the joint seated, you know, there may be some validity to that. But Invisalign certainly, you know, can work well. But using an expander like you're just showing there, I mean, I've never had a case where we just did the corticotomy and just did the bone grafting and used like a removable expander. I don't know of anybody that's done that. I would, you know, if I have my choice, I think, you know, controlling the mechanics, seeing the orthodontist every 2 weeks, using, you know, arch wires and brackets be my preference. But if it's make or break, I mean, certainly, you know, there is something to be said about using aligners, because, you know, kind of splitting the teeth together and changing them every so often. And from a compliance standpoint and a patient acceptance standpoint, it's probably going to increase, you know, patient acceptance. So, yeah. No, well, just to tell you a little bit of a story about compliance with SFOT, I had SFOT done on my upper right quadrant in October 2023, and this was in my 7th year of orthodontics, and I basically just quit on the Invisalign just as a result of fatigue. It was more of a psychological thing with me. I just couldn't do it anymore. I just couldn't tolerate the pressure on the teeth and the plastic between the teeth. It would cause me to clench and stuff. And so, I mean, as someone who's burnt out, as a burnt out patient who struggles with compliance at this point, I can see your point about how braces just eliminate the compliance variable from treatment. Yeah. I think it provides the orthodontist too more control, right? So you have orthodontists, they can bend the wires properly. They can make these adjustments every 2 weeks or so, and they can really kind of, see how things are moving individually for the patient and then adjust accordingly. Now that may be counterintuitive if you're using, SureSmile or where these robotically bent wires are already made ahead of time. But, my best results were generally when the orthodontist was bending the wires, changing those things out every 2 weeks, and just moving the patient through that. That's my perspective.
Yeah, I think Invisalign is a sexy option for people that are new to orthodontics as patients, and to prospective orthodontic patients generally gravitate toward Invisalign. But as a veteran orthodontic patient, I now see that traditional brackets and wires have so many advantages compared to Invisalign that you can only, I think, really come to see through experience. I couldn't have said it any better on. I want to ask you about the aesthetics of SFOT, and specifically around whether SFOT can have any effect on a closed mouth aesthetic of a patient. Specifically, does it cause a kind of bulging of the ridge that you can see through the cheeks? And is that a positive thing or a negative thing, or is it negligible?
My experience is that no, it hasn't. However, if you have a patient that has a significant soft tissue B point depression, sometimes when you do the bone augmentation here, it can soften that soft tissue B point. So it's not going to have like a major change like an orthodontic change, but it can soften the depression, the labial depression. In a lot of situations where patients are very crowded and now you like uncrowd them and you like align the teeth, because you have a very thin periodontium to begin with, or a high scallop periodontium, you may end up having like black triangles in between the teeth. And sometimes that may be perceived as a negative. So that has to be kind of known from the beginning. The patient has to be counseled that if that is an issue, because as we expand the arches, the interproximal peak of bone may start to reduce, and you may have these little black triangles for the teeth. So the contact zones have to be extended. And so you, if this bothers you, you may need some minimally invasive bonding, some aesthetic dentistry that, kind of go back into making sure that you have a really good, restorative prosthodontic colleagues that can kind of morph the widths and lengths of the teeth so that we have a very aesthetic outcome.
Yeah, restorative work as a complement to other airway focused orthodontic stuff has been a recurring theme. And I'll just mention very briefly, I had a MARPE provider come on and say that, sometimes if a patient has small teeth and then you make the bone bigger, you can end up again with excessively small looking teeth with the dark triangles between them. And it's always good to have a restorative plan in place so that you can get the best aesthetic outcome. But I didn't mean to interrupt. You had something you were saying.
I was going to say, also for these like airway patients, it's so important, but so overlooked in terms of having a good restorative provider, because many of these patients that have acid erosion on their teeth, the teeth are all flat. Well, I work with, I think, one of the best dentists in the country. Brian Bensay, who's works in the same building as me. He's just like a savant. He's incredible. And he'll do a lot of injection molding on the teeth to build back the morphology of the tooth structure where all this wear has taken place. So not only do we set the teeth with the right aesthetics for the patient, from the orthodontist, so they know where to put the teeth in terms of the patient's face, but now when it comes time to do the orthodontic surgery, the orthodontic surgeon doesn't have teeth that are like, skating around each other. They actually kind of can fit like a jigsaw puzzle.
Yeah, I have that problem. Dr. Gunson told me I have to do injection molding buildup on my lower molars because they're flat as a pancake.
Yeah. So that's super helpful. I mean, that can be very helpful, in getting the bite just kind of right and aiding in the orthodontics and just the overall care of the patient, right? I think sometimes too often we focus on, you heard me talk nonstop about phenotype and bone morphotype and airway, but we haven't really talked about the other consequence that's happened to all this is what's happened to the morphology of the teeth, which have worn, right? And, kind of creating those intrinsic proportions anteriorly, and then injection moldings to create the morphology of the to create the occlusal vertical dimension correctly. I mean, that's certainly, something that maybe gets swept under the rug too much, and it really shouldn't. And that's why I think it's really important to have that team, and again, somebody like, Brian Bensay, Dennis Hartley, others, in our area are really just really, really good with this stuff. Kind of can take this so-called restorative leadership and really because that's really where, all this stuff should be coming from the restorative process, right? I mean, it should be kind of at the end of all this, the teeth have to fit properly, they have to look good. And, so it kind of starts and ends with a restorative perspective, in my opinion.
Mm-hmm. Mm-hmm. And can you speak a little bit more about the activation window of SFOT, how long it lasts? Is it an on-off thing or does it taper? And can you go back in after the window closes to reactivate the window somehow?
Yeah, good question. So Ron, after the surgery, there's a latency period of about 10 days. And at 10 days is when you start to get this demineralization within the bone matrix. So you have from pretty much 10 days to about 3 months, maybe 4, to really kind of get a lot of the heavy lifting done with the tooth movement. It certainly is going to start to taper, around 3 months or so. And once you're at 4 months, 6 months is, after 4 months, you're into a pressure tension mechanics. But now you have this bone matrix, which is hopefully optimized, and you have cortical bone particles in there, you have bioloss. And now I got to think it's harder to move the teeth, than it was before, because you've got this material in there that's not, is forgiving. And so, yes, and there have been instances where we had to go back in and reboost the area or do kind of a more minimal surgery to reboost the bone to kind of get the patient across the finish line. But that's why it's really important from a patient perspective to realize that I can't see my orthodontist every 6 weeks. I need to see them every 2 weeks. And this has to begin at 2 weeks after the surgery. I got to be seeing them because their staff will sometimes say, okay, we'll see you in a month and a half. No. It's every 2 weeks for 3 to 4 months. They got to be in there, at least observation, deplaquing, making sure that we're getting the most out of this procedure for the patient.
Mm-hmm. And I think that's an argument for why it's not ever really prudent to have a remote orthodontist, because I think generally patients seeing their orthodontist remotely, especially if they're flying, will tend to only see them every 4 to 8 weeks or even less.
Yeah.
But how about SFOT as a remote patient? Is SFOT a procedure that you can easily travel for?
Yeah, much like orthodontic surgery, it is. So we will generally I like to see the patients before, for consult, evaluate if there's any mentalis strain. Sometimes patients with a long lower face height have very tense mentalis muscle or depressor anguli. Their depressor muscles are very tight. And so I will sometimes recommend Botox injections. Obviously, if we're going to change the proportions of the face, that mentalis strain can be corrected with orthodontics as well. But I just want to make sure that whatever I'm doing, if they have this strain, that we're not putting them in a situation where the flap could open or be displaced because of just the muscle pressure. So I like to see the patient a little bit, before the surgery. It gives them an opportunity to meet me, although much of this can be done on Zoom as well. So virtual consult can be done. And then we'll see the patient like the day before the surgery. We'll do a hygiene visit. We always want to have a hygiene visit done ahead of time, make sure they know how to maintain good oral hygiene and so forth. And then the surgery is done. We see them the day after or 2 days after. And then I like to see, if they're out of town, then I like to see them at around 2 weeks or so. When these post-ops become kind of like quasi-hygiene visits, because as you can imagine, somebody's not going to be brushing their teeth that much. They're going to be very careful and doing more supragingival deplaquing. So I like to see them every at 2 weeks, then maybe at 4 to 6 weeks, and then 8 to 12 weeks. And they become kind of like mini hygiene visits. And around 6 to 8 weeks is when we start to remove all the sutures, because at that point, everything should be pretty well healed. And I think remote monitoring is reasonable. But yeah, I mean, to have somebody in your back door that can kind of, be checking the orthodontic progress is important. Mm-hmm. So, and sometimes with the orthodontist that we collaborate with, like Drew McDonald in St. Petersburg is one of my favorites. He will oftentimes like do some of the post-ops, and he'll do some deplaquing, and he'll take photos and send them back. He'll send photos, he'll correspond back and forth to me. And so like having that relationship with the orthodontists, they can help manage that, and just call you at 8:00 at night saying, hey, I saw so-and-so, they look great. This is what we did. And, that teamwork is super important.
Mm-hmm. Mm-hmm. Yeah. Last question. What is the relationship between taking exogenous testosterone, like as part of testosterone replacement therapy, or even taking steroids, bodybuilders taking steroids or taking HGH? Does that work against the SFOT, or does that work with SFOT?
I would think that would work a little bit against the SFOT, but I don't have a lot of, that's something I'd have to look into. I'm not sure, but I would be a little careful with that. Also with like the bisphosphonates, that really wouldn't be a certain patient I would be doing surgery on. If they're on like long-term bisphosphonates, like alendronate, these bone anabolics for osteopenia, osteoporosis, stuff like that, that's going to impact the bone remodeling. So that's really not going to be a patient that is going to be a candidate for, elective surgery like this.
Right. And is the idea that with something like taking an HGH or testosterone that might promote faster healing of things, is that going to essentially interfere with the RAP process of wanting to create and sustain injury?
That's what I would think.
Mm-hmm. Yeah. And I ask again because a lot of my audience are
I'd
young
have
men.
to research that, though. Just to be fair, I'd have to research that. I'm not completely familiar with the impact of that on the bone turnover.
Mm-hmm. Mm-hmm. Right. Are there any other drug interactions that patients should be aware of if they're going into SFOT that they might not be telling their doctor about?
Primarily the main one would be the bisphosphonates, maybe the serotonin reuptake inhibitors, like the purple pill, things like that. Mm-hmm. That would be another one. If they're diabetic, certainly making sure that their diabetic control and their glycemic control is good. Their plaque control is excellent. Just because somebody could afford this type of surgery doesn't mean that they should have this type of surgery. If they don't know what a toothbrush looks like and they can't keep their mouth clean, it's just not gonna bode well. If they can't take responsibility in making sure that they are exceptional with their plaque control, that is key.
Mm-hmm. And what are your thoughts, just as a general periodontal question, your thoughts on these new nicotine salt products that people use, like Zyn or similar? It's a tobacco-less nicotine pouch that essentially it's a dissolving nicotine salt that is in a little pouch that people park in their gums. Have you been seeing an uptick in that sort of stuff? And
yeah, good question. No, I guess I haven't. I haven't seen a lot of that. Have you? What have others said? I just haven't.
They're huge. They're hugely popular products. They're popularized by the likes of like the Nelk Boys. Tucker Carlson, who's a conservative political commentator, has his own brand.
Yeah.
But it's essentially sold as like having your cake and eating it too when it comes to nicotine, which is obviously a amazing drug that a lot of people like, obviously highly addicting, but can be thought of as a nootropic. It gives you a little short-term stimulant boost, sharpens you up. I enjoy it, but I just worry about, the effect that it has on the gums, et cetera, et cetera. It's probably not as bad as tobacco. It seems like a very clean product, but you do feel a little bit of burn in the gum when you use it.
Yeah. And as long as it has any vasoconstrictor, potentials or anything that could compromise the blood supply, that would be the key. If there's an impact on the blood supply, that's going to be a problem.
Yeah, and I think nicotine always has that effect. I think it's bad for healing because it messes with blood flow. So interesting. So there's the local effect that the chemicals have on the site, but then there's also the systemic effect of restricting blood flow.
The other thing to be aware of are these GLP-1 inhibitors, like these like Mounjaro, these like weight loss drugs, So that has
would Ozempic fall into that category?
Yeah, Ozempic, yeah, those things. So not so much on the bone healing turnover, but on the anesthesia. So sometimes patients have to be off these drugs for a longer period of time. In other words, you can't just say, oh, don't eat or drink anything for 6 hours, 8 hours before the surgery, because they could still have food in their stomach as a result of being on these medications. So sometimes if they're taking like an injectable Mounjaro, they need to be off that drug for about a week to get the stomach contents emptied so that they are, they're truly NPO and they're not going to aspirate on themselves.
Oh, wow. Yeah, I never thought about that. So that essentially those drugs cause a kind of gastroparesis that slows the flow of food through the system.
Correct.
And then you could end up vomiting during surgery.
Well, or afterwards, right? And then they could, if they could aspirate that, then, you got a problem.
Yeah. How about cannabis and anesthesia? I've heard things about how cannabis can affect the efficacy of anesthesia. Is that true?
Well, I will tell you this. I mean, somebody who's taking a lot of cannabis is not going to be probably one who does well with moderate sedation, because you're going to be giving them Versed and they're going to be looking at you like, have you given me anything? They're very resistant to it, A lot of, and same thing I've noticed with like these ADHD medications. So patients with these anxieties, depression, anxiety meds, they just seem to combat the benzodiazepine. So having like a dental anesthesia provider who can provide them with, propofol or inhalation gases, things like that. I mean, that is going to be probably a better experience for the patient, as long as they're a safe candidate to have more advanced anesthesia done in the office setting.
Mm-hmm. Yeah, that's amazing insight, because I think a lot of younger people today are using, stimulant medications, cannabis, and other psychotropic stuff.
And then you get to the dance and you're like, the sedation's not really working for the patient. And now I've got this 3-hour procedure where I don't use propofol. I can't go any further. This is it, And so, now you fall into a situation where the patient doesn't have a good experience, and that's the last thing you want to have.
Right.
So I think that's where, you kind of let somebody else kind of handle the anesthesia part of it, and you're really putting yourself in a strong position for success.
Mm-hmm. Fantastic. All right, doctor, where can people find you? How can they become your patient? What are your socials?
I'm terrible with this. I'm not on the social media stuff. We do have, I think, something in the office. Our office website is periodontalmedicine.org, and my email is gmandelaris@periodontalmedicine.org. I think we have a Instagram page or Facebook. I'm not sure. I don't really,
So basically, they call the office and they schedule an appointment.
Yeah, pretty much. You can look online. I'll send you the SFOT course so you can share that with anybody that's interested. And thank you for having me on. I really appreciate meeting you, and I love what you're doing here. And thanks for all you're doing to help the cause.
And thanks to you for all the wonderful care that you've been giving to patients over the years. I've had patients going back 5 or 6 years telling me that you've been an advocate for them going through very tough times.
Yeah,
and I really appreciate you being there for so many patients. And you're a wealth of knowledge. And thank you for your time today, Doctor.
Thanks, Ron.